Welcome everyone to one of our BJJ podcasts for the month of February. I'm Andrew Duckworth and a warm welcome from your team here at the Bone and Joint Journal. We'd like to thank you all for your continued comments and support for our journal podcast series, as well as a big thanks to our many authors and colleagues who've joined us thus far. We also wanted to mention and hope you've had the chance to use our new and really exceptional website platform for all our journals here at the Bone and Joint, and a big congratulations to Emma Vod and all our team for the amazing work on it. So for today's podcast, I have the pleasure of being joined by one of my editorial board colleagues here at the BJJ and our specialty editor for Spine, Mr. Nick Birch. Welcome, Nick, and thank you so much for taking the time to join us.
Thanks, Andrew. It's great to be here.
Nick and I are delighted to be joined by one of my great colleagues here in Edinburgh, Mr. Athanasios Tsirikos, to discuss their editorial entitled Long-Term Follow-up of Patients with Idiopathic Scoliosis. Welcome, Thanos. It's great to have you with us.
Thank you very much for this invitation. It's great to be here.
That's great. So, Nick, maybe if I'll kick off with yourself, the editorial you and Thanos have written highlights a paper by Ragborg et al. That's also in this month's journal that has been published and looks at the long-term outcome and quality of life outcomes, in particular for patients with idiopathic scoliosis. So, Nick, just to start with, can you give us some insights, maybe from your own clinical practice in relation to this topic, along with your perspective as a spine special editor here at the BJJ, that made this paper catch your attention and prompted you and Thanos to write this editorial?
Absolutely. When I read the paper, the length and completeness of follow-up of the idiopathic scoliosis cases really grabbed my attention immediately. I mean, as time's gone on and training's become shorter and the world's moved faster, we have seen fewer and fewer really long-term follow-ups in clinic. It's in my clinic, and I've been a consultant almost 30 years. And in Northamptonshire, I guess people don't move very far. But I'm seeing now patients who I saw in the 1990s, and I've seen them intermittently since then. So I have been seeing their long-term follow-up from what I did in 97, 98, 2000, whatever it was. So I can see that. But I know that in general terms, in training, long-term follow-up is no longer really available. Of course, if you can't see the long-term follow-up, you can't see the natural history. And if you don't see the natural history, then the mistakes of history tend to repeat themselves. When I was training, my clinical training was very much governed by cases that I saw on the wards, in clinics and in clinical conferences, particularly at the RNOH. And you'd see someone who'd be coming up for years after year to the clinical conferences. And for that, it was a bit like having a hanger in your clinical wardrobe, and I was hanging off that hanger a coat, and that was the case. And then into the coat pockets, I put all of the learnings, the research as the years went by, and I always remember those cases. And they were the long-term cases, and they just stood out. And Ragborg's paper really just reminded me so much of that experience. And so I was delighted when the reviewers came back and they gave it a green light, and that we were able to publish it. And then I contacted Thanos and said, look, we've got to write something about this because it is so important in terms of modern spinal practice. So that's really how the editorial came about.
That's really interesting, Nick. And I think you're very, very much right. I think the world has moved on so quickly, hasn't it? And we don't follow up our patients like we used to, not just in spine, but in all walks of orthopedics now, and a lot related to pressure surgeries, which we'll come on to. And so you lose that natural history and watching those patients as they progress. And Thanos, if I maybe come to you next, before we look a bit more in detail at that paper, do you have a feel about, for scoliosis in particular, what is the current practice with regards follow-up across the UK, maybe your own and what you know of other people's?
Yeah, I mean, I totally agree with Nick's points. I mean, you can only learn by following the patients, and spinal surgery, as much as any other part of orthopedics, has evolved enormously in the last decades. I mean, if you think, we started deformity surgery by doing in situ fusions with just bone graft until the 1970s, where instrumentation, sort of the very basic first generation instrumentation, started. And from there to where we are now, there's a vast evolution. So it would be amazing if we could retrieve some of these old patients and see how are they actually doing. And unless they have clear complications or sort of long-term sequelae from the surgery that took place in their teens, and now they are in their sort of midlife, and sometimes some of them in the senior life, we don't really see them. So we don't get a chance to have this benefit of the continuity of care and the long-term follow-up. And there's no question that many of these patients will have issues over time. Now, they'll have issues related to the deformity, they'll have issues related to the treatment of the condition, related to the surgical treatment. And, coming back to this paper, the ability to follow patients up has been, sort of unique if you look at anywhere across the literature, and even more in our area, in the sort of Scandinavian countries, because they have the national registries and they have this huge advantage that they can always go back and look into patients. And I remember, years back, I had a lady from Sweden who lived in Edinburgh at the time, who was in her mid-40s. And, she came with an infection. She had a tooth operation and she came with a sort of really severe, sort of long-term deep infection following a posterior spinal fusion that she had when she was 12, but now she was 45. And she told me the surgeon, I knew the surgeon, a colleague in Gothenburg, so I sent him an email, and within 5 minutes, I got a reply with all the notes. And I had, the operation notes, and I could straight away find out what was used, what instrumentation, was used at the time, what implants and instruments we needed to take it out, because, obviously we needed to take it out. So, this is a sort of benefit that unfortunately not many colleagues have, or not many countries, not just us, but, around the world, have the ability to maintain. I mean, we are, sort of in an equal setup to Nick, in the sense that, Scotland is quite a close community, and, people don't necessarily move around a lot. So, we do try to chase up as many of our old patients as we can. And alongside what we've seen in this article, and what, obviously the Scoliosis Society has also advocated for longer term follow-ups, comes the need for long-term follow-up of outcomes, not just what the degrees of the curves. And we know these days that even if you end up with a 30-degree curve at the end of growth with an idiopathic scoliosis, this will tend to progress. So, we used to say to our patients that you get a 50-degree curve at the end of growth, we need to do treatment, we need to operate, because the 50-degree will progress into adult life and you'll end up with a more severe medical problem. But actually, that's not true. We know that 40-degree curves and 30-degree curves will progress. Now, they won't necessarily progress to the point that they need surgery. And this has been demonstrated in this, Danish, paper. Yeah. But it doesn't mean that, you can still ease them up and say, okay, well, there won't be any problems in the future.
Yeah.
And I think it would be great, and that was one of the points I made when we were reviewing this paper, that it would be great if we had clinical outcomes for this group of patients. But of course, it is difficult always to go back, so many decades down the line and try to pinpoint all of these details. But it's one of the things that I think will be becoming, more and more useful, and almost an obligation. One, to defend our practice, but also, to be in a position to say, actually, what we're doing is really making a difference to the patients, not just producing a better X-ray, but actually, the way to be able to tell that, you're actually making a difference is how the patient respond, to the treatment.
Absolutely, Athanasios. I think it's a really nice overview of that paper, and like you say, the ability of the Scandinavian countries in particular, it was 71% follow-up rate at over a median of 40 years is just truly remarkable, isn't it? But as the paper says, it does have a significant impact on these patients' health-related quality of life, and it's an important point, like you say, that you need to know that your intervention, if it is surgery, for example, is making a difference to them. Maybe moving on, Thanos, because you briefly mentioned it there, and you mentioned it in the editorial, the SRS has identified the importance of long-term follow-up for these patients. Yeah. Do you have any insights into the background of that, or how that's sort of come about, and what they maybe envisage, for that in terms of the research in that area?
Yeah, and yes, and I think, this is a very good point, and it's something that we have also discussed within the British spine societies over the years. But the Scoliosis Society, being the sort of the world leader in deformity surgery, they have a sort of a wider impact across different countries. But there is a lot of argument around the treatment that we offer. One, because it is very, high risk, and there's no question that, when we're talking about, patients being paraplegic as a risk of surgery or becoming paraplegic or even, having a risk of death. Yes, we say that, there's a very small risk, but, it's not negligible. And if it happens to that one patient, for that patient, it's 100% risk. So, these are very, major procedures that, what we do needs to be solidly, sort of validated. We need to be in a position to say that, well, actually, we do make a difference to the patients, not just in terms of producing a better X-ray, but producing, hopefully, a better quality of life and sort of avoiding pain in later life and have a sustainable result, not just as they move into, early adult life, but later on. It used to be, and that was also a recommendation by the Scoliosis Research Society, that every, clinical series should have a 2-year follow-up. And of course, 2-year follow-up for pediatric adolescent surgery doesn't mean anything. It's utterly useless. I mean, you operate on a 14-year-old and you see them until they're 16. Okay, they're probably fully grown. What does that mean? That doesn't tell you anything what's going to happen 10, 20, 30 years down the line as they progress into, a life of more activities, more career planning, having a family, having a totally different demand, like physically, emotionally, psychologically. So I think it is critical that, we do follow this lead and, in whatever way it is possible, trying to keep some contact with our patients. One way that helps, and we've done that in a similar way in the UK as the Scoliosis Society has done in the US, is creating registries. Yeah. And the British Spine Registry has helped a lot because, that is a way to document, results, complications, revision rates, all of these things, but also hopefully go back and retrieve your data. Yeah. One of the things, I always put in my presentations, I always produce every year a graph which comes from the registry. So the registry gives it, to you, and you can go back and chase all your patients who have been on the registry, have their outcomes, and we use validated questionnaires, obviously, to be able to see how their quality of life, has progressed over the years. And you can do your pre-op, immediate post-op, 6, 12, 24 months, but also then longer-term follow-up. And we are now looking into our results beyond 10 years and beyond 20 years. And I think that would be extremely, useful. So I think this is what the SRS is trying to pass as a message. Again, the Scandinavians are leading the way because they have, this ability of maintaining contact with the patients and having them all on a database, a national database. But I think, in the UK, we have a great opportunity to maintain that quality of data collection and look into our outcomes.
Absolutely. And I think it's a really interesting point you make about the registry and how that can potentially help. And also your analogy of 2 years, if you relate that to our arthroplasty colleagues who follow them up, for 10, 20, even 30 years, that's what we really, like you suggest, what we really should be aiming for. And actually looking at the potential deterioration that these patients can actually have, as has been shown in the Danish paper. So Nick, if maybe I come back to you now, because, obviously we've talked a lot about the Danish paper, but your editorial very nicely goes through how that knowledge has maybe evolved over time and how the literature has evolved. And so for our listeners, can you maybe sort of summarize that and maybe some take-home points from it?
Yeah, the first thing that stands out in the literature is there aren't that many very long-term studies on idiopathic scoliosis. And the ones that there are they come along every 10 years or so. So interesting, because the first one that really sticks out was in 1968, again, a Scandinavian study from Nielsen and Lundgren. And in that paper, they actually they said the orthopedic surgeon should concentrate on patients whose age makes them particularly susceptible to progression of the scoliosis, and that most attention should then be paid to the opportunities for active therapy. At the same time, little is known about the fate of scoliotic patients after they've left the orthopedic surgeon's immediate field of interest. that speaks exactly to what Thanos was just saying, exactly what you're saying, Andrew, and that is that, a couple of years of follow-up is absolutely worse than nothing. And they go on to say an analysis of the vital prognosis in idiopathic scoliosis and an account of the social and socio-medical functions of these patients is required. Well, this is what Ragbold's done. This is exactly the whole approach that Thanos has just been illustrating, that the SRS is trying to get. So I thought that was very interesting. So that's back in 1968, which most of our listeners, I think, weren't even a glint in their parents' eyes in those days. Now, by our standards, that paper was relatively low standard of evidence, but it was actually quite a good observational paper. The Iowa cohort from Stuart Weinstein's group, and we do an apology to Professor Weinstein, because we originally had quoted that as Ponsetti's group, and of course it wasn't. Ponsetti was there as a, if you like, a courtesy author. It was very much Professor Weinstein who was driving that in the two papers they published back in the 1980s, etc. And they looked at a phenomenal group of people, 219 patients seen originally between 1932 and 1948, but they focused on backache and curve progression. And they said there wasn't very much evidence of backache actually in this group of patients, and functional loss at 39 and 50-year follow-up periods was not that great. So they were reporting quite good outcomes. I mean, Jackson in 83 was more pessimistic. He said half of their 197 patients at 10 years had chronic pain, and that was related to the curve extent, particularly in lumbar spine, which is what you'd expect, and their age. And the older they got, and the worse the lumbar spine problems became, the worse their pain became. So Mike Edgar and Min Mehta reported the Stanmore results in 88. And that was a nice study, because what they did was they got everybody to skeletal maturity, and then they looked at them 10 years after that. So it wasn't as though they were seeing patients who were still developing within their follow-up time. So they knew exactly where they were. But I mean, the cohort was split roughly 50-50. It wasn't exactly. And they concluded that fusion reduced the incidence of long-term back pain, but not backache. I'm not quite sure what back pain and backache are, because I deal with backache and back pain all the day, every day. And, patients come along and say, my back hurts and my back aches. It's all the same. So not quite sure quite what they were saying, but they did say that surgery seemed to have some benefit with that.
Yeah.
So that was, again, an optimistic view of the long term. And then you have to jump a couple of decades until Danielson, another Swedish paper, a Nordic paper, reported 2010 on the 16-year follow-up patients with moderate curves not treated with surgery. And they said, well, look, in the 30s, these people are the same as people who don't have scoliosis. So they're fine. But that's the 30s. What happens to the 40s, the 50s? What happens when you start to get secondary degenerative changes with mild curves? And then you begin to get the onset of genetic influences on your discs. That we know that 80% of disc degeneration is genetically determined, and 20% is what you do in your life. Well, past that 20% is going to be scoliosis. And are these then the cases that then lead to this real tsunami of adult degenerative scoliosis cases that we're now seeing? It's the typical patient you're seeing in the supermarket who's leaning on her trolley because she can't stand straight because she's completely out of sagittal alignment. Is this what these mild curves are doing? And we need to know, because we need this long-term data. And really, the last few papers in the 2010s, there was last in 2019, and Barshad he was in 2020, I think, and they were looking at that. They were saying basically there were pretty low levels of disability, low levels of back pain. So much of the literature, first of all, methodologically, it's difficult to make it good. You have to take it as it is. It's an observational study.
Yeah.
But Ragbold, of course, they've got the data from early on. So we've got better methodology now because of the registries, as Thanos has said. And as we're building that up, we'll continue to have better methodology. The optimism of the good outcomes, I think, actually is that little balloon's being punctured by what we're seeing in this latest paper. And I think what we're really seeing is what I see in my clinic, and that is that there are patients who've got significant rotation within the center of a degenerate curve coming up as is it a de novo adult degenerative scoliosis? Well, no, it probably wasn't. It was probably an AIS that's then developed into a degenerate scoliosis, and that there's then been an olisthesis at L3-4 or whatever else that's then tipped it over. And so you're getting this mixed picture. And I think that That's the bit that we really need to understand from these long-term studies. And I think that Ragball's paper is contributing to that.
No, absolutely. I think it's a lovely overview of how it has evolved. And like you say, the methodological quality, you could, we all look for these high levels of evidence, but that's the best that is out there. But that, like you said, how that Ragball paper has sort of, like you say, painted a much less rosy picture than previous reports is very interesting. So maybe that sort of takes us nicely, I suppose, and sort of the final sort of question I had for you both really is, and we've sort of touched on it a bit, but sort of, how do we then, moving forward, because I know what people will say is that, yes, we need to follow these patients up from what we've said, but, we work in a very resource-strained environment, and providing or getting long-term follow-up is more and more difficult. So how do we balance that out? Maybe Thanos, I'll start with you. How do we deliver that without unduly burdening the health service that's already pretty strained?
There's no question that it is challenging, and the economical aspects of all these conditions is quite sort of affecting healthcare, whichever way you look at it, in terms of initial treatment, in terms of need for support for these people later on in life, in terms of exactly as Nick said. I think the two sort of striking points that I would make is, one, obviously, try to keep good databases. I think that is essential. So, in a prospective way, keep track of all the patients that come through the services, and ideally then document, these patients in a registry. So, the registry should have the ability for, people who, say, colleagues who would like every, now and then, maybe every 5-10 years, to go back and retrieve the data on a national basis, not just on a local basis, and then go and look into different aspects that, can sort of quantify, quality of care and how is that maintained, over time. So I think that would be very, very useful. So, collect as much transparent data as possible. Hopefully motivate people, to document, these patients, because that is one of the problems we've had. The level of compliance has been quite low in many services, and, through the societies, we've tried over the years, to try to make this almost mandatory. So in other words, especially, in England, where, you're paid by results, if you don't document the patients, you don't get paid. So there is a lot of sort of sideways pressure, to try to make this work. But I think the more accurate the data that is collected, the more the results and the value of the results that can come out of this. That is the one thing. The other point, which I think is very important, is that there has to be a bridging between pediatric and adult services. In other words, you don't want to have, separate services. And I'll use the example of North America, where much of the deformity surgery on the pediatric and adolescent side is done by the pediatric orthopedic surgeons. And of course, they stop seeing the patients as they get to the age of 18. Some centers, where I worked in Delaware and Philadelphia, they used to see patients up to the age of 21. But again, 21 is not enough to maintain follow-up. The length of follow-up that you need to be able to see the complications or to be able to see the problems, whether it's for untreated patients, whether it's for braced patients, whether it's for surgical patients, because all three groups should really be monitored. You want to have a natural history study of all three categories, the untreated, the braced, or the treated, the surgically treated. So I think, that doesn't work. So these patients then disappear from the pediatric services. They go to adult services, and they probably get dispersed across different, clinicians and different, services, and they're lost. And there's no way to follow them up. Iowa has always been a unique sort of setup, and, Professor Weinstein has been really motivated, sort of personally motivated to collect data over the years, and he has done an amazing, work, not just in sort of natural history studies, but also, for instance, in, brace-based studies that, have been landmark in how we treat these patients. So he has to be certainly, acknowledged for this. In our setup, like in Europe and in the UK, we are now moving into the model of having, deformity alongside, degenerative spine and alongside, the acute spinal work. And I think that gives the ability for this bridging to occur across. And hopefully it will give us the opportunity to follow patients up. And, if you have this combination of, good local, documentation of what has been done, databases at the local service basis. So, say in Edinburgh or in Manchester or in Leeds or in Sheffield or in London, what have you done? What are your patients? Try to follow them up. And this is where, again, maybe having people who have more of a research type of role, because, you'll always find it almost impossible to retrieve patients to come back to clinic, to be seen in clinic, to have x-rays, to have, tests. That is where, obviously, we have huge pressure from the health service and it's impossible to do it. But to do like telephone type of surveys, to send, questionnaires out, to try to see how they are scoring years down the line, should be feasible with some maybe, not clinical and non-clinical support, so research type of audit type of support. And then go through the registries, try to work that on a national basis, and then use like the Scoliosis Society, which again, they've always looked for 2-year follow-up, but it would be great if they could go back and try to extend this follow-up to, longer years and into adult life and into hopefully from decade to decade, longer term, and see what happens. I think that is the only way, to be able to, to validate what we're doing. And at the end of the day, for risky procedures, for costly procedures, to be able to offer the maximum benefit to the patients. And accommodate problems that will come, longer term down the line.
Yeah, no, absolutely, Thanos. I think that's two very clear points and very well made about how we can potentially do that. Maybe, Nick, same question to you. I mean, I suppose the other thing I was thinking of, along the lines of a lot has changed in healthcare and how we interact with our patients because of COVID. Is there any sort of novel methods you think we could maybe use as well?
Absolutely. I mean, you'll recall, of course, the article by Hans G. and his colleagues, and including our editor-in-chief, Faris Haddad, last year, looking at exactly this. And they looked at all of the various techniques that we can use in arthroplasty follow-up and how we can apply some technology. And really in spine, we're not much different. So I think the first thing, to Thanos' point, is essentially to say telemedicine. Let's record proms over the telephone, over a video link like this. And, it's not going to be very long before we start to get some clinical history bots. Instead of chat bots, there'll be clinical history bots. And they'll be able to have an avatar and they'll be able to interact with people. And the people who've got scoliosis now and been treated in their teens and 20s are going to be very familiar with these sorts of technologies, and they'll be absolutely fine. And I don't think there's going to be a problem with that. We tried it back in the 1990s for diagnostic algorithms for back pain and tried to understand patient-reported outcomes from that. It didn't work because we didn't have the computing power, we didn't have the software technology. We are developing that now, and AI is moving forward at such a rapid rate that I don't see it very, very long before we can actually start to do most of our routine, non-urgent follow-up through a telemedicine AI approach. The second really then comes to the second part of the assessment. So we've got the history, which is the prompts, the AI, the avatar. The second is the assessment of the examination. How do we see whether somebody's curve has progressed? And now modern digital technology on our phones is such that we can use them. We can go back to the old days when we were using moire fringe type approaches. We can look at that. We can put grids on our phones and we can see whether somebody's 3D shape has changed from year to year to year. And because of the accuracy of digital photography, we can be pretty sure about that. And I remember going to a 3D spinal shape conference in 1994 in Pescara in Italy, was the first scoliosis conference I ever went to. And they were talking about things like moire fringe type technologies then, but they just didn't have the technology to make it work. I think we actually will have those in the coming years. And then the other part is actually about the treatment of patients and actually chronic pain management. How are we going to allow them to access good treatment to manage their pain if we know that they're getting chronic pain? And I'm involved in new technologies, things like home-based neurofeedback training, which is really looking at how you can alter people's brain waves to allow them to become more able to manage their chronic pain. And this has been very successful. And this is going to be rolled out in the next few years. And I think that's going to become something that is just home-based, and we can then look at them remotely, treat them remotely, and then react as needed. So they then come into the clinic only when it's absolutely necessary for Thanos to see them or his colleagues and say, look, there is a problem now and we need to do something different. And I think that's probably going to be the type of approach that we have in the next couple of decades.
No, absolutely, Nick. I think that's a really nice point to finish on in terms of how it will evolve. And like you say, I don't think it will be long before these ambitions and sort of aims are sort of realised. I totally agree. Well, both sincere thanks for joining me today and highlighting a really important topic and how we might move forward in this area, what we've just touched on there, and not just in scoliosis surgery or spine surgery, but in several areas within our specialty where that longer term follow-up and assessment is really still very important and valid. So it was really informative and so nice to talk to you both. And to our listeners, we do hope you've enjoyed joining us, and we encourage you to share your thoughts and comments through social media alike about what we've discussed today and the papers we've discussed. Feel free to tweet or post about anything and here today. And thanks again for joining us. Take care, everyone.